I'm David McGuire, Senior Analyst in the Policy Team at the King's Fund. I'd like to welcome you to our event today. As you may have seen us highlight in the description of the event, for the last 20 years, advances in technology and clinical practice have transformed the pathways patients' journey down as they receive care. The advent of population health and place-based systems, digital technology will become a key underpinning of the new structures the NHS works with. Amongst other things, it'll empower information sharing across organisations. I'm delighted to be joined by a fantastic panel of people putting this into practice across England and Wales, who I'll introduce in just a moment. But first, I'd like to thank our event sponsor, IBM, and I'd like to explain how this session will work. As we're recording this ahead of time, we've accumulated a list of questions from yourselves in the audience during the registration process, and we'd like you to submit more questions via Slido. You should be able to see a box next to the video, which is where you can submit your questions. Our speakers are watching live with you, and we'll be able to respond to questions on Slido. We'll also be putting some poll questions and some word clouds to you through that same box. These are going to flash up at various points during the session, again, on the right-hand side of the video. Please do follow along with and engage with the conversation on Twitter via our hashtag KFOnline. And do take a look at the resource tab that you will be able to find on the page as well. That'll come up again at the end of the video once we've finished. And this video will also be available on demand later on. So to the panel. Joining me today is Dr. Karen Kirkham, National Clinical Advisor in Primary Care with NHS England, and the Integrated Care System Clinical Lead and the Assistant Clinical Chair at Dorset CCG. Karen, could you tell us a little bit about yourself and your roles and how those interact with population health management and integrated care, please?
Thank you, David. Thanks to everyone for joining today. So I'm a clinician. I will still work as a GP, and I work in a number of places. First of all, I work within Dorset as the Integrated Care Clinical Lead, with a real focus on population health management as it drives improvement in our system. I also work within the national team, also looking at our approach to population health management as part of driving forward integrated care systems. I'd just like to talk a little bit about the Pop Health Management Programme in Dorset. So that we've been on the programme for about 18 months, and essentially this allows us to drive the data to produce intelligent insights which then allow us to make actionable changes within our care pathways. It allows us to totally redesign some of our care pathways to focus and target on high needs. It allows us to address inequalities, which has been really, the COVID crisis has really shone a total spotlight on the health inequalities within our system, and allows us to think about the use of our resources in a completely different way. It's engaged our clinicians and our managers together with a single common purpose for change, and it has allowed us to build very strong primary care networks with a real view on how they manage their patients, but in a total community managed way. So it allows us to think about the different workforce, the different community assets that we have at our that are available to us to help drive change. So it links our primary care networks to our wider system. It allows us to break the barriers between primary and secondary care, but really importantly, it starts to help us to think about a different way that we might deliver care. And certainly, we've really seen a rapid digitalisation in some areas as we've proceeded, particularly through the last few months, which has seen a real acceleration of our progress. So I thought it might be helpful just to give a few illustrations to try and make this point. In the early stages of our population health management programme in Dorset, we started with a focus on respiratory disease, looking at where we had the highest rates of admission for COPD. By linking the data sets, and now we have real time, every 24 hours uploading of linked data sets, we now can risk stratify our population so we can see which patients are of greatest need. And for that number of patients, we put in very specialist expert groups, making better use of secondary care consultants. For those who are at lesser need and who don't require that same level of intervention, we've moved to a much more personalised approach to care, the use of apps, asking patients really to start helping themselves along the course of their illness, always with a view to, if those patients escalate, to be able to provide something different. Through the COVID crisis, I can give a couple of examples of where the change has really happened. One has been in the early days, we were able to risk stratify and segment our shielded population. We were able to join them up with social care so that very quickly we were able to get support to them. And we made use of social prescribing link workers to really support patients in a very targeted way that hadn't been before. And then moving forward, as we enter the second wave now, we are using our data to help identify those patients who would be at greatest risk should they develop COVID. And when we see those positive tests coming through, we're identifying those patients with comorbidities, with other reasons that they could deteriorate quicker. And we're using the data to help us identify those patients and get some remote monitoring in place early to help us identify early detection and early deterioration of their conditions, using digital means, putting in place apps, working together collaborative across the system, and really truly working together as one system, whether it's a primary, community or secondary care, all working together to common aim of patients. So population health management is a tool for change. It enables us to use the data to drive intelligent decision making, and universally is a golden thread that will run through redesign and reconfiguration for whatever we do. Thank you.
There's some really exciting ideas there that hopefully we'll be able to explore more during the discussion part of our event here. I'm also joined by Lord Victor Adebowale, who is here in his role as co-founder and chair of Visionable. Victor, could you tell us more about some of the work that you've done embedding tech into the journeys that patients have gone through in their care?
I guess Visionable is a video platform. It's software. It's designed to work with clinicians and patients as a single platform, enabling. It doesn't matter whether it's hospital, primary care system, secondary care system, single platform. It holds no data, so it's secure and it is interoperable with most hardware platforms. Visionable's been operating for about 5 years in its current form, and we operate in about 100 NHS institutions, including hospitals. I think we operate in 1 in 4 of the 100 top hospitals in the UK. The example that I probably would want to talk about is our stroke network and the East of England stroke network, which has been studied quite a lot and is on the shortlist for the NICE Awards for clinical pathway design. As you know, stroke is the 4th single leading cause of death in the UK, and there are more than 100,000 strokes each year, according to the British Stroke Association. And it's critical that you have timely access to urgent care and treatment, such as thrombolyzation, which is crucial for survival and recovery. But there have been, for some time, national variations in care across the country, and in the quality of that care and the use of telemedicine. We took the Visionable platform as a means by which we could look at some of the underlying challenges and use Visionable to address some of those. So we designed with the East of England Stroke Network an integrated telemedicine service using secure video conferencing, Visionable, for rapid access to stroke consultant support in the East of England. And it became part of the East of England acute stroke care pathway, and compared in a study which was carried out by University of East Anglia. It was compared to usual care during out of hour periods. So we looked at the health economics of this methodology, and we used it, and we also looked at the impact on thrombolyzation and on the impact on the number of days people with stroke spend in hospital, which on average is 17 days. And what I can tell you over the period of the study, which I haven't got in front of me, but that the number of bed days were reduced from 17 to 4. The percentage of thrombolisation increased from 1% to 40%, and the savings of the period of the study was in the region of 19 million pounds. So a kind of practical example of how telemedicine can be used in a specific care pathway to increase access to clinical decisions in stroke, improving the treatment of stroke victims, and increasing both the economic efficacy of that treatment in a wide area. I mean, the telemedicine service patients covered 2,588 patients which accessed the telemedicine service during the period of the study, and 1,111 of them were thrombolised within the time period.
Thank you, Victor. I think we're going to also come back to that point about variations in care when we come to the question and answer section as well. We'll move through the rest of the panel as well here. There's plenty of people that we have yet to introduce. We've also got Paul Mears, who is Chief Executive at Cumtath Maganwig Health Board in Wales. Paul, could you talk to us about the strategy in your area and some of the ambitions that you have around transforming pathways?
Thanks, David. So yes, as you say, I'm Chief Exec at Cumtath Maganwig Health Board. I have to caveat saying I've only been in the job 6 weeks, so my perception and feedback on this is going to be early days assessment of where we are. Just set some context. Obviously, in Wales, the system is slightly different in that the health boards are responsible for everything. So my health board is responsible for public health. We're responsible for primary care, community services, and I have 3 acute hospitals within my health board area, as well as mental health services, community children's services, and everything. So the advantage in Wales in some ways is the infrastructure is integrated. I think the reality is that even though we have an integrated organisation, we're still not anywhere near as integrated in terms of the way we deliver our services as we should be, and that's part of what our challenge is as an organisation now moving forward. It's also important to say that the patch that we look after is goes from Bridgend and Porthcawl down on the coast, right up the Rhondda valleys, up to some very deprived parts of Wales, ex-mining communities where we have a lot of challenges around deprivation, poor health and well-being, lots of issues around social determinants of health which are not good in terms of lifestyle choices, unemployment. So some significant challenges, and particularly challenging when you look at some of the outcomes for our population around things like cancer and our outcomes for cancer patients, which are particularly poor in our part of Wales. So one of the key areas we are really looking to improve on is the way in which we manage our cancer patients and try and improve the way we deliver care for our cancer patients. Like everybody, we're seeing a growth in cancer diagnosis, and that's putting quite significant pressure on our diagnostic capacity and also our treatment capacity. So one of the things we are looking at doing now and working with colleagues at IBM Watson is looking at is how can we use some of the augmented reality types of solutions, or augmented intelligence, to actually start to streamline the way in which our pathways operate. So starting to think about how do we make the decision making more streamlined for our clinicians, and also importantly in my eyes, how do we make the experience more streamlined for our patients, because I think people going through cancer pathways can often feel that the pathway is quite fragmented and quite at a time when people are very concerned, understandably, about what might be happening to them. We need to make sure that the pathways is as streamlined as possible. So we're really keen to look at how we can use technology and some of the new AI solutions that are out there to improve the rate of diagnosis, so it speeds up the time, the diagnosis rates, but also it streamlines the way in which our patients interact with our services. So we're working very actively on that at the moment. We've got a long way to go. I think we're only literally just starting those conversations now, but we think it's a really good opportunity to take some of the technology that's now becoming quite widespread in healthcare around the world and think about how we adapt that to our particular local circumstance.
Thank you very much, Paul. Don't worry, speaking as someone who used to work in the Northern Irish system, it's one thing to have an integrated organization with other parts of the service. It's another thing to actually be able to live it out. Don't worry, you're not alone struggling with that. Next up, we have Dr. Avi Mehra, who's an associate partner at Watson Health and IBM. Avi, could you tell us a bit more about what you and IBM are hearing about some of these applications of technology to the patient pathway and journey?
Sure, thanks, David, and really happy to be here on the panel today. So I'm Avi Mehra. I'm a general medical doctor by background and associate partner with IBM and IBM Watson Health, where I've been for the last 4 years, working both in the UK and internationally. Prior to joining IBM, I was a practicing doctor in the NHS and also held various roles in the digital health space. So my current role with IBM is really focused around working with healthcare organizations to think how we can improve care delivery, leveraging our technology capabilities and things like analytics, artificial intelligence, and so forth, and also our services expertise. And just to build on your point, David, around some of the discussions we've been having with various NHS organizations around this. So we've been having a number of discussions with different NHS organizations, of course, including Paul in Wales, and really around how we can improve care pathways. And it's really clear the challenges we're seeing are significant and wide-ranging. As we've already heard from panel members, COVID-19 has placed an absolute significant and immense strain on an already stressed healthcare system. So one overarching need we're hearing right now is around a need to quickly find innovative solutions that can really help free up capacity, but also free up clinician time so that we can really focus on delivering care and helping patients to move through the pathway faster. Some other common themes and challenges we've been hearing in the space, and sort of building on what Paul and other panel members have already said, cancer pathways, again, to re-emphasize, are in particular under great strain. They're clearly some of the most complex, expensive, and time-critical pathways. And patient backlog within cancer pathways is obviously a really critical issue for trusts across the NHS. Even just managing multidisciplinary team meetings in an effective and efficient way can be very challenging in the current crisis. We're also seeing issues with the ability to track and monitor patients effectively and manage flow through the pathway. This lack of data intelligence or sort of pathway insights really means that bottlenecks are building up. They're not able to be identified or addressed quickly enough, and leading to subsequent delays in diagnosis and initiating treatment, and really means that patients really can't move through the pathways fast enough. And very much related to this point, an issue that is coming up a lot is to do with the underlying IT infrastructure and IT system interoperability along the pathway that is a key blocker to making change at the pace we need to. And we're getting a lot of requests for support with not just being able to bring the data together from these disparate sources, but also with the initial data discovery efforts to really help trusts to understand what is happening, why is it happening, and then so what can we do about it, and really how can we turn the data into actionable insights and use that to redesign workflows. And then of course, we're of course seeing the impact of the huge workforce shortfall and burnout manifesting itself across the pathways. So I think, as we're moving forward now, it's really important that we think broadly about care pathway transformation in its entirety, and not just thinking about sort of digitizing single discrete episodes of care, but also how we leverage technology and data and the momentum we've already built with digital health adoption as that sort of key enabler to facilitate service redesign amongst the pathways.
Thank you very much. I think there's some really important underpinning principles there in what you just said about the quality of data that is being collected and shared, as well as the infrastructure to provide that data. That's absolutely key to some of the challenges they're currently facing, areas that are now moving towards their ICS status or moving on from STP. But I should also introduce our final panel member. It's Mark Dowdy, who is the Director of the Centre of Patient Leadership and a Senior Consultant in the Leadership and Organisational Development team here at the King's Fund. Mark, what does all of this look like from the perspective of the patient and their family? How can we make this use of technology inclusive towards stakeholders from a wide range of groups?
Thank you, David. It's a very interesting question. I live with a number of long-term conditions that influences my relationship with the healthcare system I'm a part of. I access primary, secondary, community services on a regular basis, at least once a month for all of those. And that has influenced my experience, and also my background also influences my experience. And one of the things that I'm aware of as a patient is, what do I want to get from accessing services? And what I particularly want to get is the ability to be able to receive timely care and safe and quality care and treatment when I need it. And any support and technology or digitalization of those services, I think, needs to pay attention to the fundamental thing that myself and others that I've talked to, who also are patients accessing services, raise, which is fundamentally just that: the ability to be able to access the care when they need it, not to be excluded because of where they live or who they are, not to be denied treatments or services because of that, but anything that can help provide that is really important. And therefore, I think that those people who are designing and developing services, digital services for the NHS, for health and social care, I would just ask them to keep in the back of their mind some very simple questions that we can easily take for granted, or they get lost in the design process, or the pressures of designing something within limited budgets or under time pressures. And that is, what is the purpose of this? What are we designing these services for? Who are we designing these services for? So if we're thinking in that way, then I think another question I would be asking the designers and the developers is, how do we know we're actually improving the experience, improving the quality of care, and the treatment that patients and their family members and their carers are receiving? How do we know that? How do we know we're being effective? Because it's very easy, I think, to put in place measures which assume that you're taking into account the patient's needs and wants, but actually they can easily get lost. I would expect to be at the center at some point of this design and developmental process. And if you do that, if you have consciously put patients at the center of your digitization process, then I would hope that you'd be taking account of all the people, all the members of the community who you are offering care and other services to. They would be part of your thinking. Inclusivity would be part of that process of ensuring that the technology, ensuring that the work we're doing around digital work would definitely take account of the needs of all your community members.
Thank you very much, Mark. We now turn to the question and answer session of the discussion. I'm going to put some questions to our panel now, and we'll see how many of these we can cover from yourselves that you contributed in the slide you might have seen during registration. As I said earlier as well, you can still contribute questions that we'll be answering live during the session in that slider box that you can see next to the video. If we could start perhaps by talking about some of those variations in care that some of you's covered, and the challenges of providing care to different groups. This is going to become more and more important as we start to move towards place-based care here in England in particular. Victor, you mentioned it yourself in your introduction there. You work in a number of roles across healthcare and other areas as well. What are some of the conversations that you've seen happening at the local level around this?
Well, I think to take the macro, there are only the sorts of things that I've seen throughout my sort of career in healthcare and public policy generally lead me to think that there are only really three challenges in healthcare. The first is equity, and what I mean by that is the fact that I'm sitting here in London right now. In Barking and Dagenham, which is a poorer borough of London, the active life expectancy of a woman is 55. In Richmond upon Thames, it's over 70. So that is not sustainable in any rational form, and that is a real access. So by which I mean the way in which we design services so that we have positive value transfer, so you get as much as possible in one place as opposed to going to several different places. That's wastes both time and money of both the patient and the NHS, and it's the second challenge, and that challenge is met by both workforce design and the way we design services through commissioning. And the third challenge is digital. So the example that I gave you, which is one I'm absolutely connected to, it illustrates something which is really important about digital, which is that if it's not helping with the first two challenges, i.e. equity and access, why are we using it? So we know that poverty and stroke are associated. We know that access to thrombolisation is variable. We know that there's a shortage of stroke specialists. So therefore, the technology that we apply has to both deal with the equity issue, people who are most likely to suffer from stroke getting the service that's designed to their needs, the access issue, which means that you're able to actually apply technology that gets the stroke consultant to see the patient wherever they are. In our case, that can be in an ambulance, because our technology does something that others doesn't do, which is multiple camera points. And to my colleague from IBM Watson, it's one of the reasons we're talking to you, because we can have several streams of data going in at any one time, which other technologies won't do, and actually allows people to receive thrombolisation, an increased level of thrombolisation, rather than as a standard rather than a variable. So thrombolisation over the last 10 years has gone up. It's now between 11 and 12% across in the UK as an average, but there are quite big regional national variations which are fundamentally unacceptable. And so what we've done in the east of England should be available everywhere. It's not, it's perfectly possible, and there's very little rationale why someone who has a stroke or an ischemic incident or whatever shouldn't receive exactly what people who receive a service from the East of England Stroke Network get. And that's why I use that example. We can't continue. Population health will fail unless it deals with equity and access.
And Paul, Karen, how's this interplaying with your work in your areas?
So variation is absolutely something we're living with on a daily basis. Even within our health board area, with nearly 500,000 population, there is variation between our local areas. Similar to the example that Victor gave there with this sort of life expectancy variation, we have similar variation across even just our health board. So it is a massive challenge for us. And I think one of the responsibilities we have in sort of leading health services is to try and make sure that we bring outcomes for everybody improve, but particularly the outcomes for the people who are in the most challenged areas. I think often that's those are areas, and if I look at the patch that I'm now responsible for, I think the reality is most of the issues that those people will be living with that are impacting their health are actually not issues that the health service directly would be responsible for. It will be about their employment, it will be about their housing, it will be about education, access to leisure facilities, self-motivation. The communities I'm responsible for, these are communities for many, many years that have had challenges in terms of industrial heartlands that have been stopped, mining communities where there is no more mining, that the employment issues around that we're still dealing with the consequence of that now. So I think this is the interesting conversation, I think, about inequality and outcomes is actually how so much of it isn't relating to health services directly. It's other factors that influence people's lives that are determining their health, and yet often in the health service we fix the presenting complaint or the issue that we're dealing with in the GP surgery or in a hospital, but actually our bigger responsibility, I think, as health service leaders is to work with our voluntary organisations, communities, other public sector organisations to try and work on a strategy for how we improve the determinants of ill health rather than the consequence of ill health.
And also then perhaps just to give a kind of I guess a clinical and also a non-clinical slant on that. I think very much understanding where that variation occurs and elevating it into spotlight is really important. There are so many areas that don't understand their data, don't know their data, haven't got access to that kind of intelligence. So that kind of, for me, is the first step. And then application of evidence-based pathways and adherence to those pathways, making sure that there is absolute join up between all elements of the care and sector, giving that time to embed those change, look at where tech can be applied to improve, as Victor said, the access and the equity around that, and make sure that we're thinking digital at any change and any redesign process. And then I think really paying attention to the amount of time it takes to undertake that change management program. So there's one thing about redesign, there's quite another about making sure that change sticks, and then auditing the process as you go out. So a real kind of QI methodology around that is imperative. And if we do this in a scientific way, methodologically, all the way through, then I think we do stand a chance of understanding. But it all starts with the data, and it all starts with having the ability and the infrastructure design to be able for any local health system to understand where are the gaps, where are the opportunities, and where are you going to start? Because we all need to start somewhere.
Thank you, Karen. There's something there about, I think during this whole conversation so far, if I'm remembering correctly, none of us have used the phrase IT department so far. And it feeds into something I wrote about a couple of years ago in a King's Fund piece. The implementation of digital technology is not a IT change, it is a clinical change. It is part of the evolution of the care that we provide. Mark, how do we make sure that the patient voice is heard meaningfully in all of this? After all, we can't have equity if people aren't being heard properly, can we?
Got to be careful I don't sound like a broken record, because we go right back to the fact that if patients are at the heart and the center of the services that are being designed and delivered to meet their healthcare needs, then it should be obvious that their voices need to be heard in order that what goes into the design of these services is relevant to their health and care needs. But it so easily, if we're not careful, can become less important. And sometimes things get taken for granted. So language that is used in the health service, in health and social care, wouldn't be my natural way of understanding my experience. So patient pathway is not something that I'm familiar with in my role as a patient engaging with the healthcare system. Language like patient journey is not something that comes to mind. It's not easy for me. Even less easy is the idea that I'm flowing through my patient pathway. If the language I'm using to explain and understand somebody's experiences is not something that they can empathize with, then there's a real disconnect potential between the relationship of the person in either designing, delivering, managing healthcare services and the person on the receiving end. So if you want to make sure you're hearing the patient voice, then ask. It's really simple, because at the heart of this, as I said, is relationships, and at the heart of a relationship is the ability to seek to understand one another, to ask questions, and ensure those questions are understood by the other person, and that you're asking questions that are truly going to make the needs of the other person. So again, empathizing with the patient and their experiences is critical if we're going to design services that really matter, that really deliver. A colleague that I've worked with in a cancer centre in South Wales, and she's called Kate Hammond, and she's a patient experience manager down there, and they wanted to offer to the people using their services the opportunity to use telephone or video to, rather than coming in, because the assumption was that coming into the hospital could be a struggle for a lot of patients. It wasn't easy, and particularly because of the nature of their condition, it could be quite painful experience, physically painful. But what they discovered was when they actually asked patients, a number of them said yes. If it's a routine appointment, a checkup, I certainly don't mind that. But if that was going to be my only means of connecting with your centre and the services you offer and the people delivering those services, then I don't think I would like that, because I actually get an awful lot from making my way in and meeting others in the outpatients area, connecting with them, having an opportunity to speak with them, and realizing that I'm not alone with my condition, that other people are experiencing what I'm experiencing. So that sense of community that's in that outpatients area is really important to me. Yes, I'd like the choice of whether I come in or I do it online or by telephone, but please don't take that choice away from me.
Thank you, Mark. Just on the next question, where along that pathway, that patient journey, can we most usefully leverage tech and make an immediate impact with digitization? There's so much pressure on the NHS right now between COVID and financial issues and demographic issues, workforce shortages, that often we find ourselves talking to clinical and senior leaders in the fund who need to make short-term moves that have long-term impact. Does that feel reflected in the conversations that you've been having, Avi? And do you see any clear examples coming through in your work of how that comes through?
Yeah, absolutely, David. So I guess first to mention, through the pandemic so far, we have already seen rapid adoption of new digital tools and technologies to really support a new model of care delivery, which has been quite amazing to see. Everything from virtual care and telehealth platforms, changing the way we deliver care in primary care and elsewhere, collaboration and communication software solutions, different online channels. So we've got a lot of momentum there right now in terms of the adoption of digital health. But I think to your point, where can we make the impact quicker? So how can we start in those areas of high value where we can make an impact fast, but also are somewhat lower risk, so that we can get things implemented in a much faster and yet scientifically robust way? And I think, thinking about it, if we split it into sort of clinical versus back-end or administrative use cases, I think some of the lower hanging fruit in terms of making an impact faster with technology is really around the sort of back end administrative use cases, really using technology to facilitate those process and productivity improvements. For example, using technology, whether it be artificial intelligence capabilities or things like robotic process automation, to automate some of those time-consuming administrative tasks that clinicians and staff members spend a huge amount of time doing, whether that's just booking tests and appointments, triggering referrals, things like supply chain management. And we've seen this being introduced really well in other industries. Other examples, like we talked earlier around using technology to help with patient tracking and resource allocation along the pathway, really, in a sort of dashboard-like way to help the trust with making those decisions and making sort of more effective resource deployments where they're really needed. And some of the work we've also been involved in as IBM during the pandemic is really around patient and staff engagement. So we've in a couple of cases worked with NHS organisations in both England and Wales to deploy AI virtual assistants to help both providing information to staff and citizens around COVID-19. So I think in terms of making a faster impact, those, using technology in some of those sort of administrative areas, especially when we're talking about things like AI, can get things faster. But of course, we need to complement that with a more long-term strategy, and that's where the harder sort of clinical use case is, where we're using technology to support and augment decision-making, to support with treatment recommendations, to support with screening and things like triage. Those will absolutely become paramount, but building the evidence base to get them implemented is going to take time.
Karen, if I can turn to you here, that's quite an interesting point that Abby's touched on there at the end, because you talked about the changes that you've seen in the initial stage of the work in Dorset. What were some of the things that your partners and funders were asking for in terms of what they wanted to see from some of the transformations? Because this is one of the things we often hear from people about. We get asked for the same thing in multiple different places from private suppliers, or our CCG is after something very particular from us when it comes to funding for X or Y from trusts. What did that feel like to you in your area?
Well, certainly, in addition to everything that Avi has said, the importance of joining up healthcare records across the system, of huge importance. When Dorset started its journey around transformation 5 years ago now, and we brought clinicians together, the first thing they said was, we've got to have an integrated healthcare record, please. That's the single most important thing that we can have, and that is not only allows us to provide safer care, but it's truly joined up, and it allows us then to use that as a platform for a whole host of other things, not least the kind of decision making and ability to enhance the administrative function that we're talking about. So joining up records, I would say, is essential. Second is connected provider collaboratives, and I choose those words carefully, because that's acute provider collaboratives in the current system has to be enabled, as well as the primary secondary alignment as well. And then the third is around patient connectivity. So trying to modernize and industrialize the NHS patient connectivity in the way that many other industries already have. And I think I've seen this massive change in not only in the way that we're consulting with patients, but with asking for advice from other clinicians in our acute sector and community and mental health sector, for that matter. Mental health has made an enormous stride in remote consulting, absolutely on a pin changed the way that it's providing its services, as we have done in whatever sector, and also in general practice. But thinking about the way that we interact with patients and the expectation of a more electronic consulting, able to communicate in real time with patients is going to be something that I think we're going to see much more of, in addition to all of the other the ability to use technology to enhance the diagnostics and so on. And automating the processes, I think, not only just gives us much more productivity, is absolutely the expectation now going forward. And we need to grab all of these opportunities and move them. but I think trusts have to really update their infrastructure to be able to do this. We've seen it being rather precarious in some areas where old technology is just not able to provide us with the platforms going forward. And I think there is a big question that we need to ask ourselves about the amount of investment that's been made in some of our big organisations in terms of just getting the infrastructure right to be able to move forward with the changes that we want to bring in.
Thank you, Karen. I think to keep us moving through the questions, I'm going to move on to the next one. Paul touched on some of this in his introduction, his previous answer, and Abby mentioned some of it as well. The pandemic has had huge implications for how digital technology is used, both within patient care, but also very importantly in back office functions. That might not sound as interesting or spectacular, but it's absolutely essential to putting in place closer links and smoother working across organizations, as Karen's just mentioned there.
Thanks, David. Well, first of all, I think I'd echo just what Karen said there, because I think one of the things that is become very evident for our organisation over the past 6 months is the infrastructure that is needed to make this a reality. And I think, you know, to be the best one in the world, our guys have done an amazing job to make it work in an extremist situation, in an within an infrastructure that frankly is not that stable and robust. So I think one of the things which we do need to think about moving forward as our organisation is, what is that infrastructure that we're going to need if we're going to truly use new digital technologies to drive innovation in the way we deliver clinical care, or indeed engage and involve our patients. We're going to need to make sure that our infrastructure is capable of doing that, because there's going to be nothing more frustrating than if we start to rely on some of these technologies and clinicians just don't have the reliability of the system behind them. And if I'm really honest as well, if you're not even able to enable people to log on to their emails from home, starting to have conversations with them about, you know, how they're going to use AI to do their, you know, radiology diagnoses is slightly starts to fall on deaf ears, because people say, well, yeah, but get the basics right first before we start to talk about some of the sort of more fancy stuff, which I think is a very valid point. So I think there's something definitely, as Karen said, about the infrastructure. I think the other thing which is become apparent to me, and I did a piece of work on this prior to coming to Wales, is looking at the AI opportunities and the new technology that's out there. The thing about how do we make it an integral part of the way we train new clinicians, because I think at the moment we're in that slight transitory phase where we're trying to sort of enhance the understanding of people who trained in medicine or nursing or whatever it was several years ago. So there's something for me about how are we factoring in to our training programs for new clinicians the use of this technology, which is going to become mainstream. I mean, a lot of the people who are going into medical school now will be clinicians who in 10, 20 years times will be using AI as a core part of the way they undertake their clinical practice. But I'm not necessarily sure that we've thought through how those sorts of technologies and new ways of doing things are built into training. And that's not just in terms of pre-registration training, it's also part of, you know, individual organisational training and development for our staff. So one of the things I'm thinking about in our organisation is how do we build sort of training and education around these things into the day-to-day work. You know, we expect everybody clearly to be competent in their clinical practice to be able to operate effectively in our organisation. But I think at some point in the future we're going to be at a place where we'll have an expectation that everybody has a basic level of understanding about these sorts of technologies to enable them to be part of our organisation in the future. So there's a training and education piece to this. And then finally, I think there's a big question for me, and some thought needs to be given about how we put the governance and infrastructure around these things, because, you know, at the moment it's very clear individual clinicians have clinical responsibility for patients, that the buck stops with them. We start to get into the world of AI and new technologies, it becomes a bit more blurred. And, you know, at what point does a clinician's individual responsibility begin and end, and where do we sort of draw the line, and where does it sit around governance and things like that? So it sounds slightly you know, tedious, I know, and a bit sort of clunky to have to have those conversations. But I think, you know, these new technologies need to be implemented in an environment that is safe for the clinicians to operate and provides the security for the patient, that they know that the information they're providing is going to be held securely, and also that the decisions that are being made, often by the technologies, are going to be appropriately overseen as well.
And Victor, if I can quickly turn to you and ask, what excites you about how we might develop the use of technology in health and social care further off the back of the pandemic period and some of the change that we've seen?
Well, it's really interesting. It's great to hear the comments from the other panelists. I think the future is exciting, providing we do the following things. The first is we have to ignore the notion of moving fast and breaking things. This is health. We have to work in partnership with clinicians. I've seen too many technologies applied that don't have the clinician in the lead. I think the clinician and the information specialists need to be in lockstep. But at the end of the day, it's the clinician that has to make the decision using this technology. In February, I co-edited the BMJ magazine. We looked at AI in detail. We've seen a lot of peer-reviewed and other papers relating to AI, and it's a complex. It's not straightforward. I'm sure, as Avi will set out. And so one of the things we have to look at in AI is some of the built-in prejudices that may mean that certain patients, certain communities don't benefit. And that's a governance issue as well as a technology issue. People talk about AI as though it's a general thing. There are different types of AI, different types of learning machines and environments, and we have to pick the right type of AI and machine learning for the right environment. Firstly, secondly, to Karen's point about population health and data, I think you're absolutely on button. I mean, you know that anyway, but I just think it's really, really important. But the NHS, if it learns from its past about how it uses data and how it turns it into information, has to recognise that there are two types of data, and both are important: quant and qual. And in population health, I think qualitative data, patient experience, how you work with them to design services, is as important as the quant data. And we haven't learned that lesson enough. Indeed, that lesson was the foundation on which the NHS was built, and we seem to have lost it somewhere. And the third point I'd want to make is that actually I'm quite focused on what we can do now, not just sort of dreaming about the future. So to Paul's point, and other people have made this point, an example would be, we have a shortage of certain, we talk about the back office, we have a shortage of some really important clinical specialisms like stroke, for instance. Actually, what we can do now is use technology to make full utilisation of the specialists that we've got. So out in Kent, where Visionable is, we have literally like a takeoff and landing centre that can connect specialist clinicians to patients and systems from wherever they are, actually in the world, but certainly in the UK, so that patients in this equity and access point can get the expertise that they need, and we're using those clinicians to their maximum utilisation where we have shortages. So I think, bearing in mind those things that people have said and I've added, I think the future, what's happened during COVID has been terrible. One of the learnings from it is that we can move really fast to implement technology in the interests of patients. What we have to do is just stop and learn from this period. What was good, and there were several hundred things that were good, but what wasn't so good, without blame. So some of the procurement issues were really tricky. I think some of the failure to learn from local experience was really tricky. Some of the qual data about what works, we didn't apply. Let's do that rapidly and move on. And that's how we build in what we've learned from what has been a really testing and tragic period.
Thank you very much, Victor. If I can turn now to Avi quickly here and then close with Mark. Avi, we're starting to talk about some of these more complex technologies, maybe stuff that people aren't as familiar with, things like AI and other machine learning processes. Could you talk quickly about some of the things to look for in implementing those and making sure that they work properly?
Yeah, no, and to Victor's point, it isn't easy, and we have to make sure the technology doesn't widen the health inequality gap, and starting with sort of robust evaluation and assessment of technology that's been introduced so far is absolutely essential. But to your point, around AI and data, I think we really need to be, we need to be very mindful in terms of how it's being used and in what use cases and in what settings. And as we talked about earlier, we need to focus initially on getting the basics right. Things like, so with AI only will work if you can get access to large volumes of high quality data that is representative. And if you're introducing bias into it just from the data set that you're using, that's going to have manifestations in terms of the AI algorithms that are being developed. So we really need to be very careful and considered around how we do this. Really, to other panel members' points around really getting the basics right, and that starts with the IT infrastructure. So being able to get access firstly to the data from the fragmented and disparate IT systems is step number one. Making sure that data is high quality, is complete, is representative, is not biased, and making sure there's governance to ensure transparency associated with that data. We need to be very transparent in terms of what data is being used, in what context, and how it's being used, and what algorithms it's being used to train. So we absolutely need transparency. And of course, when we're talking about AI, we also need this concept of explainability, right? It cannot be a black box system and black box approach. We need to be able to show how, if we're using an algorithm to augment certain aspects of the care pathway, how is it being used and how are the algorithms working? And of course, supplementing that with, really robust education and training. I think to Paul's point earlier, we need to start that really early on to make sure that the clinicians, patients, staff members who are soon going to be tasked with embracing these new technologies and ways of working really have the education and training that they need to understand it, to be comfortable with it, to have confidence. And of course, that feeds into the overall change management effort that's required when you're bringing in new technologies, and especially when you're doing it in the context of service redesign, which is ultimately what's required here.
And finally, Mark, how do we make sure that the patient voice that we've heard in the last few minutes is so important, is heard and recognized, and that there's trust for people in how their data is going to be used? Because we've already seen some groups are starting to lose trust in how the NHS handles their data during the course of the pandemic, and because of other instances like care.data. What reflections do you have on some of those things that have already happened?
I assume this from the work I've done with many patients, which is care is a relational thing. It's it's based upon the qualities that are exhibited by both parties in a caring relationship, the person delivering the care and the person receiving care. And I mention that because in the question you've asked, you talk about trust, that people, how can they trust the data? And they've had that trust tested at times. Well, again, we go back to the relational aspects of this. I'm going to trust somebody if they earn my trust, and they earn my trust by how they show up in the relationship I'm having with them. There's a degree of openness and honesty. Do I feel that they're really seeing and hearing me as a person as well as a patient? Am I being treated with dignity and respect? Am I receiving compassionate care? And is there an element of transparency in that relationship built on openness and honesty? And if that is the case, and that has to be explicitly named, I think, as something which is a key part of the caring relationship, if that is there, then the design and the development of services, digital services around that, should always hold at its heart, at its center, that perspective of trust. And part of that also means the ability to recognize that if you make mistakes, or if something hasn't gone the way you expected that it has, you own it, you're open, and you learn from it. I just want to sum up, I think, by saying, I would just say though that we must never forget who this technology is in service of, and why we are developing it. And this means we really need to think about how we include the patient, their families, their carers, their communities in the design and the development of these digital services. And in order to do that, I would suggest that focusing on what co-design really means, what working in partnership with patients really means, and what it and how we do it is critical.
Thank you very much, Mark, and thank you to everybody watching. We're now coming to the end of the event. I'd like to thank Paul, Victor, Karen, Avi, and Mark for joining us. Please do feel free to share the link to the event with your colleagues and your friends. Like I said, this event will be available on demand. There's also going to be a feedback button that will appear at the bottom of your screen after the event asking for feedback. We really do value it. We'll send you a quick survey link in an email shortly. And yes, if you could fill it out, that would be fantastic. It lets us know what you want from future events and helps us to make them better. I'd also like to thank our sponsor, IBM, and also to remind you quickly that resource tab is available down the bottom of the screen again too. Thank you very much and have a good day.